Moving to integration, you have to think about what the previous, in some cases, the current system is. Let's take it from a patient's experience. If I'm a patient and I have to go see my primary care physician. And during that visit, there's some concern related to depression. In a lot of cases, in a system where physical health and behavioral health are separate, that patient leaves with a referral. That patient then walks into a clinic, a behavioral health clinic, that they may not be familiar with. It's likely they're going to be asked to fill out new paperwork. It's likely there's no communication between the primary care physician and the behavioral health specialist that's going to treat them. They have to go through that same experience, that same discussion with a new person. It's duplication, it's waste in the system. In a fully integrated system, you get referred to an individual within your network, somebody in a familiar place, a familiar face. I think when I think about integration, think about it from the patient's experience, and that's why we're doing it. Healthcare is local. Local communities understand what their needs are. Southwest Washington went live in April 2016. We learned a lot from that. We have 2 managed care organizations that I think are doing a good job. They had to build networks. I think there was some challenges early on with those networks, and by networks I mean doctors are available to actually see patients. We spent a lot of time making sure that those patients have really access to care. In Southwest Washington, I think it's going well, but it wouldn't have gone well without the engagement of the local community leaders from the counties within those regions. North Central, we're about a month in. It's February right now, so just over a month. I think overall it's been going well. There's about 75,000 individuals that receive services in Chelan, Douglas, and Grant counties. In those counties, we had to reassign clients, and clients had to choose to go to new plans if they wanted to stay with their current doctors in some cases. When that county went live, that region actually went live, we had daily phone calls. We listened to the community. We listened to providers from both physical and behavioral health. We worked closely with the managed care organizations. In those daily calls, we heard about cases where individuals would show up and they didn't know which plan they were assigned to in some cases. They didn't know that they lost eligibility in some cases. It's our job to help work through those. I think in the case of North Central, we worked through those issues and we continue to work through those issues. It's all about communication. It's all about listening and sharing our story. Prior to go live, we sent notifications to clients, letting them know something's going to change. Then we sent a little more detailed information about what's going to change. And then we sent their change notifications. We had staff in the region. We should have had an office in that region at this point. We had staff there so often, really communicating with the local providers to make sure they have what they need. And also partnering with the managed care organizations who have the responsibility to ensure that the care is actually provided. We worked very closely with the community. We prepare authorization files, so if an individual is moving from one managed care organization to another, we get that information and then we share it with the new plan so that there are no gaps in care. It is a federal requirement that we ensure that managed care plans contract with adequate number of providers by provider type in order to meet the needs of the clients that we serve. We have about 1.6 million clients that are served through managed care in our state. We have a very robust process. I'm proud of the process that we have today, but it's going to continue to get better.